welcome to our video on sunburns and photoaging. So we're going to start with sunburns. And for both of these conditions, we'll go through the definition, the pathophys, as well as the risk factors, how they present, and then how you diagnose and manage, and most importantly, how you prevent these issues. So let's start with the definition of a sunburn. Okay, a sunburn represents an acute inflammatory response of the skin, and this is in response to ultraviolet radiation from the sun. And here we can see a clear representation of a sunburn on a patient with fair skin. And when you look at this, you can see there's a clear demarcation between where there was protection from UV light and where there was sun exposure. So in other words, his t-shirt actually protected the patient from the sun, but didn't protect his neck. So you got this clear demarcation. So that's typical of most sunburns. Most of us have seen these or experienced them. So as I already mentioned, sunburns result from rays from the sun that carry ultraviolet radiation. And specifically, it's ultraviolet A and ultraviolet B rays. And these ultraviolet rays cause DNA photo damage, and within the skin that it penetrates, it triggers the inflammatory cascade. So this DNA damage results in apoptosis of keratinocytes, which are in the epidermis. And because of that apoptosis, there's release of mediators of inflammation, such as prostaglandins and nitric oxide. And that apoptosis and the inflammatory mediators together lead to inflammation of the dermis, and that gives rise to the sunburn. Now, there are several risk factors that can increase the likelihood of developing a sunburn and the likelihood that the sunburn will be severe. And the first risk factor is age. Sunburns occur more frequently in adolescents and young adults because they're more likely to spend time outdoors and they're less likely to take the time to use protective measures to prevent a sunburn. It's also more likely to occur and to be more severe in those patients with fair skin and blue eyes, or if they have red hair or blonde hair. And that makes sense because they have less melanin in their skin, and melanin provides protection from ultraviolet radiation. So less melanin in your skin means more susceptibility to ultraviolet rays. And there are also conditions related to the exposure to ultraviolet radiation that can impact the likelihood of developing a sunburn. So first, a sunburn is more likely to occur in the midday, when the sunlight intensity is the greatest. It's also more likely to occur when there is a surface for the rays to reflect off of, such as snow, water, or sand. And if you've ever been snowboarding or out on the water during midday when you see that light just reflecting and almost blinding you, you can think, this is one of those experiences that can make the sunburn more severe or more likely to occur. It's almost like your eyes telling you that. Now, the latitude and altitude can also impact the amount of ultraviolet radiation that one is exposed to. For example, the closer one lives to the equator, the longer they will experience sunlight throughout the day. And high altitudes increase the risk of a sunburn because the intensity of ultraviolet rays reaching the skin is greater at high altitudes. Now finally, a lack of photoprotection, such as sunscreen or protective clothing, can increase the risk that somebody will develop a sunburn. And that's fairly intuitive. And a sunburn will only be present in areas that are exposed to UV radiation. However, it's important to remember that ultraviolet radiation can penetrate through light-colored or even wet clothing. And sunburns typically present with erythema 4 to 6 hours after you're exposed. And that actually peaks in redness approximately 12 to 24 hours after the exposure occurred. And that same erythema will typically resolve by about 72 hours and can eventually develop into scaling, desquamation, or a tanned color. Now, it's important to know that sunburns can lead to either first or second degree burns. If the burn is limited to erythema, you classify it as a first degree burn. And if there are blisters present, then you would qualify that as a second degree. While the blisters are painful and represent a more severe sunburn, they will not scar once they heal. And interestingly, in addition to those blisters, patients with severe sunburns can also experience systemic symptoms, such as a headache, nausea, vomiting, and fever. So those symptoms alone would make you think, it's a pretty severe sunburn, so probably second degree. Now in this image, there's a clinical picture of a more severe sunburn with blistering, and you can see an area of well-demarcated erythema on the shoulder. And in the center, there's an area of even a more severe burn because you see the blisters. Now clinically, this would be described as a bulla since it's fluid-filled and it's greater than 5 millimeters in diameter. And you can also see smaller vesicles surrounding the bulla, and those are defined as fluid-filled lesions less than 5 millimeters in diameter. So how do you diagnose a sunburn? Well, it's pretty straightforward based on the history and how it appears when you look at it. However, the patient should also be evaluated to ensure that they're not prescribed any drugs that can lead to photosensitivity. So these drugs are doxycycline, thiazide diuretics, and amiodarone. All of these drugs have metabolites that react with ultraviolet light to cause cell injury, leading to a sunburn-like rash, and that can occur within minutes to hours of sun exposure. So if further history reveals a patient is on one of these drugs, you got to encourage them to closely adhere to photoprotective measures because they're just at higher risk. So how do you manage it? Well, the management is also pretty straightforward. If it's mild to moderate, you're basically just trying to treat the symptoms. So cool compresses, calamine lotion, and aloe vera gels, those can provide relief of pain that's related to the sunburn. But if the patient has any blisters that rupture, you want to clean them and cover them with a wet dressing. But now let's assume that the pain is not well controlled with the cool compresses or lotions or gels. Well, in this case, you can do the next intuitive thing, which is to provide analgesics such as NSAIDs. Now, if the patient has a severe sunburn, it's possible that they may require hospitalization. And this is due to the fact that severe sunburns, because of their blistering, cause capillary leaks and can even lead to hypovolemic shock. But we need to think about why you want to hospitalize them in the first place. Well, one, if they're hypovolemic and they've lost a lot of fluids, then you're going to want to make them hemodynamically stable and replace any of the fluids that are lost. Also, while they're in the hospital, you may be able to better control their pain than you would be able to if they were at home. But now think of those blisters that have ruptured. So one thing you'd be worried about here is the lack of protection that the skin normally provides against infections or bacteria. So with these popped blisters, you want to give topical antimicrobials. These include silver sulfadiazine or mupirocin. Again, that's all to prevent infection. Okay, now let's do a quick question. A 57-year-old woman comes to the physician due to a rash on her face, back, and hands. She first noticed the rash 2 days ago after returning from the beach. She has a past medical history of chronic atrial fibrillation treated with amiodarone, osteoarthritis treated with acetaminophen as needed, and genitourinary syndrome of menopause managed with topical estrogen cream. Physical exam reveals erythema and several vesicles on the face, back, and hands. Which medication is the most likely cause of this patient's condition? So feel free to pause the video and take a moment as you consider this question. Okay, so the patient presents with erythema and several vesicles on her face, back, and hands after returning from the beach. So that's fairly consistent with a sunburn. And the question implies that there's a drug causing photosensitivity, making this patient even more vulnerable to ultraviolet radiation. So with that in mind, which one of the drugs that she's taking can increase the risk of photosensitivity? Well, she's taking amiodarone, acetaminophen, and a topical estrogen cream. Of these medications, the one that's most likely to cause a photosensitivity reaction like this is amiodarone. Recall that the 3 drugs you want to lock in your mind about photosensitivity are doxycycline, thiazides, and amiodarone. Okay, now let's talk about how you can prevent a sunburn. So a sunburn is relatively preventable, especially if patients take basic photoprotective measures. So what are these measures? Well, the most effective method to control a sunburn or to prevent it is to avoid exposure to UV radiation. So not letting the sun ever have its rays reach you. You can do this by seeking shade during the hours with sunlight, or at least when it's most intense. And obviously wearing clothing can protect your skin from the ultraviolet radiation. And what times is sunlight most intense? We say midday, so in most locations you can say from 10 a.m. to 4 p.m. Now, if a patient really wants to be in the sun, then just make sure they use sunscreen. Try to encourage that. And what they should be using is broad spectrum sunscreen, so at least 30 SPF, and apply that 15 to 30 minutes prior to their first exposure. And thankfully, a lot of these instructions are pretty basic, and they're also included on sunscreen bottles. So as long as you get your patient to at least put on sunscreen, then there's a high chance that they'll look at this and can remember that they need to apply it before they go out and reapply it regularly. And how often should they reapply it? Well, every 2 hours, or if there's any water exposure. And that actually includes sweat. If there's any heavy sweating, then that's considered water exposure. And there really isn't such thing as waterproof sunscreen. So just make sure that your patients are aware that if they are going to be wet a lot, they need to be reapplying sunscreen frequently. So now that we've covered sunburns, let's move on to another consequence of sun exposure, which is photoaging. So photoaging is defined as premature skin aging due to prolonged and repeated exposure to solar radiation. Some characteristic findings of photoaging include wrinkles, dyspigmentation, and loss of elasticity of the skin. And photoaging occurs when chronic ultraviolet radiation exposure leads to the loss of structural integrity of the skin, which kind of makes sense because we were saying that there was that loss of elasticity. So really be thinking about the structural integrity of the skin being broken down. So here's what happens. UV rays will damage the DNA and lead to the formation of reactive oxygen species. So very similar to what we were talking about with sunburn pathophys. So these reactive oxygen species will activate receptors for cytokines and growth factors within the skin. And one of these growth factors is transcription factor activator protein 1. And that's the main mediator of damage in photoaging. So this transcription factor upregulates matrix metalloproteinases, such as collagenase, which of course leads to the breakdown of the matrix of the skin, collagen. And that same transcription factor also inhibits pro-collagen gene expression. So not only does this transcription factor activator protein 1 kill or destroy existing collagen, but it prevents more collagen from forming. So obviously pretty damaging. And those two factors together lead to a decrease in the total amount of collagen in the skin and the breakdown of the dermal matrix. So that leads to those signs of photoaging. In this image, you can see the histologic findings of photoaged skin. At the top of this histological image, there's flattening of the dermal papillae with a loss of the ret bridges. And in this image, you can also see signs of solar elastosis. And this is that basophilic material in the dermis that represents disintegrated elastic fibers and collagen breakdown products. So what are the risk factors for photoaging? Well, they're actually very similar to the risk factors for a sunburn. So one of the biggest risk factors is age. So the effects of photoaging are due to chronic ultraviolet radiation exposure over long periods of time. So older patients are much more likely to experience the effects of photoaging. Another risk factor is fair skin. So there's less melanin, so more opportunity for the ultraviolet rays to damage DNA and cause upregulation of that transcription factor activator protein 1. So less melanin means more of that bad protein. And males are also at an increased risk of photoaging because they've been historically more likely to have occupations that involve significant amounts of time spent outdoors. So it's less related to their specific gender and more related to their occupation. Now finally, high levels of sun exposure also increase the risk of photoaging. And that one's probably the most intuitive one, almost not even worth saying. The more you're exposed to the sun means the more sun exposure you get, which means the risk of photoaging is higher. Pretty logical. But it is important to recognize that some professions or hobbies can increase the time that one spends in the sunlight. As we mentioned before, with males, by comparison, have more jobs outside. But something else that's very interesting is knowing geographic location can also impact how much sun the patient gets exposed to. Remember that when we were talking about sunburns, that altitude and latitude can increase sun exposure. Now, the features of photoaging can be slightly different in fair skin and darker skin. In patients with fair skin, photoaging may present as wrinkles, solar elastosis, lentigines, actinic keratosis, and loss of translucency and elasticity of the skin. And senile purpura is a finding related to photoaging that presents as ecchymotic macules. And those are predominantly present on the forearms and the dorsum of the hands, and you can see those in elderly patients. And this senile purpura occurs due to blood vessel fragility secondary to the dermal atrophy from chronic sun damage. In other words, the skin is damaged from the sun, and that damage leads to blood vessel damage. So the idea is that these blood vessels can rupture and create purpura even with only minor trauma. So in this way, you can think of your healthy skin with its structural integrity intact as actually protecting your blood vessels. Now, another finding that may be present on physical exam in elderly patients is actinic elastosis. So this finding will present as thickening and yellowing of the skin, and that's secondary to damage from ultraviolet radiation, chronic ultraviolet radiation, and disorganized collagen. This image here shows senile purpura, and this purpura can be on the dorsum of the hand, and on this case, we're looking at the dorsum of the forearm. And that's the most common location of senile purpura. So you get these small ecchymotic macules. And what's damaged here? It's actually the blood vessels. Now let's talk about photoaging in patients with dark skin. So this will typically present as wrinkles and irregular pigmentation. These changes typically present almost 10 to 20 years later in patients with dark skin. And that delayed onset is actually due to the fact that these patients with dark skin have an increased number and an increased size of individual melanosomes, which basically means they have more melanin, which we already knew because they have dark skin. And because of that melanin, they have more photoprotection. So their findings aren't going to be as severe as a fair person. So how do you diagnose photoaging? Well, thankfully, it's very straightforward. Like most things in dermatology, it's based mostly on clinical appearance. So in this image, you can see the close-up findings of photoaged skin. The most clear sign really is in those wrinkles. But if you're looking carefully, then you can notice some areas of subtle dyspigmentation. So how do you manage this? Well, the most important part of the management of photoaging is to educate the patient about sun protection measures to prevent further damage. However, if the patient is really bothered by the appearance of photoaging, then they can try topical retinoids to improve the appearance. In fact, topical retinoids are the first-line treatment to improve the appearance of photoaging, and those are agents related to vitamin A. So retinoids, vitamin A. Now the mechanism of action of retinoids, like the reason they work, is because they actually increase collagen production and they induce dermal hyperplasia. And in that process, they actually decrease the atypia of keratinocytes and melanocytes. So all of those things together can lead to improved appearance of even skin that's been already damaged. Now, what about the patient experiencing actinic keratosis? Well, what you can do in these cases is apply topical fluorouracil. This agent actually creates this epidermal injury, which is then healed by the body. So that process of healing leads to remodeling of the dermal matrix and can actually improve the appearance of that area. Now, the prevention of photoaging will follow the exact same principles as the prevention of sunburn. So we'll just review these briefly now. So avoid the sun, in particular seek shade during those midday or high intensity sunlight times between 10 and 4, wear protective clothing, and use sunscreen. Okay, now let's do a quick question. An 87-year-old woman comes to the physician reporting skin lesions on her hands and forearms. She noticed small purple dots gradually increasing in number over the past few years. She lives in a nursing home. Her vital signs are unremarkable. The physical exam reveals multiple diffuse purpura on dorsal hands and forearms. There are no similar lesions anywhere else on her body. Her affect is normal, and she enjoys conversation with the physician. How does this patient's skin condition differ from bruises induced by abuse? Okay, so you've got this elderly patient with diffuse purpura localized on the dorsal hands and forearms, and there are no other signs elsewhere on her body, and she has a normal affect. So those findings altogether make elderly abuse less likely and actually favor the diagnosis of senile purpura. And recall that senile purpura is caused by dermal atrophy, which can lead to fragile blood vessels. And that's actually a normal finding in the elderly population. However, it is important to be able to distinguish this senile purpura from bruises induced by abuse. So here's a fact that you're going to want to lock away. Bruises caused by abuse are usually located at the sites where spontaneous trauma is unlikely. For example, the flanks and buttocks. Additionally, bruises induced by abuse are usually larger than what you'd see in senile purpura. So here's a table that you can use to review sunburns and photoaging, specifically the important aspects that you need to remember. Now let's wrap up with a board-style question. A 25-year-old woman presents to the office due to a rash that she noticed after her hiking trip this weekend in Arizona. It began about 6 hours into her first hike and became progressively worse over the next day. She has a past medical history of atopic dermatitis. Her family history is significant for psoriasis in her mother. Her vital signs include a temperature of 38 degrees Celsius, a blood pressure of 120/75, a heart rate of 91, and a respiratory rate of 15. The physical exam shows an erythematous blanching rash that is most prominent on her forehead, nose, and forearms. The rash is painful to light touch and pressure. What is the best treatment option for this patient's condition? A. Topical triamcinolone. B. Silicone gel sheets. C. NSAIDs and aloe vera gel. Or D. Oral antihistamines. Okay, so this patient presents with an erythematous blanching and tender rash on her forehead, nose, and forearms. And she noticed this after a hiking trip. Now, given the possibility of excessive sun exposure on a hiking trip and the distribution of this rash on her, that's actually really consistent with a sunburn, which I'm sure you already came to that conclusion when you were reading this. So what's the best treatment option for her, given that she's hemodynamically stable? Well, what you can do is give NSAIDs and aloe vera gel, because really you're just trying to treat the symptoms. So the correct answer is C. And just going back to this slide, this is where we discussed the management options for a sunburn. So mild to moderate, it's all about the symptom relief. Severe, you're trying to replace fluids and prevent infection. That doesn't fit our patient. But now let's discuss why the other options are incorrect. So option A, topical triamcinolone, is incorrect because although topical steroids can be used in many dermatological conditions, such as psoriasis, they've not been shown to be effective for sunburn. Now option B, silicone gel sheets, is incorrect because that's actually used for hypertrophic scars, not for sunburn. Finally, option D, oral antihistamines, is incorrect because although they can be used in conditions like atopic dermatitis, they're not useful for a sunburn unless the patient has a concomitant pruritus, in which case it's treating pruritus, not the actual sunburn. So D is wrong. And the correct answer is C, NSAIDs and aloe vera gel. And that concludes this lecture.